one of the questions I get with almost every talk that I give about memory, which is, what do you mean by dementia, and what's the difference between dementia and Alzheimer's disease? So dementia essentially means you've got some kind of a progressive brain disorder that's adversely impacting a range or multiple cognitive abilities, and it's causing a need for assistance with your everyday activities. So progressive loss of multiple types of cognitive ability with a need for assistance in a broad range of activities, well, that's dementia. Alzheimer's disease is that, it's dementia, at least that's the traditional definition, it's dementia, and you think it's due to this thing called Alzheimer's disease, which means plaques and tangles you would see in the brain. But since we can't see that under the microscope unless you do a brain biopsy, which we never do, but what we use as a surrogate markers for these plaques and tangles are a couple of things. Either a brain MRI that's mostly normal, except for very profound localized atrophy of certain parts of the temporal lobes of the brain, certain parts of the brain. We don't often get that pattern. What we get more often in people with Alzheimer's disease is a lot of the brain has atrophy, and you don't see this big imbalance between temporal lobe atrophy and atrophy elsewhere. Or another way of making a diagnosis of probable Alzheimer's disease is cerebrospinal fluid. So they can do a spinal tap or a lumbar puncture, where the person doing the lumbar puncture numbs up your back and puts a tiny needle in to the back below the level of the spinal cord and lets some fluid drain out, send it to the lab, and you can send it for tests for proteins that go along with Alzheimer's disease or are associated with Alzheimer's disease. And so what we typically use in our area is amyloid tau index, which has to do with, somewhat confusingly, a reduction in this amyloid protein, which the amyloid protein builds up in the brain, but in the spinal fluid it's low, so it's confusing. And so amyloid protein, and then there's another protein which is called phosphorylated tau, and there's a ratio of the amyloid protein and the tau, and it doesn't really make much sense. The tau part makes sense because in the brain of an Alzheimer patient, you build up these tangles that are filled with hyperphosphorylated tau, and if you look at the spinal fluid, you see an excess of phosphorylated tau. So that part makes sense. The A-beta part in the spinal fluid doesn't really make sense, but the bottom line is there's an empirically identified pattern of proteins that you can see in the spinal fluid that put you in a category that's either probable Alzheimer's disease or borderline maybe Alzheimer's disease or not Alzheimer's disease. So spinal fluid is maybe our best test we have right now. The other test that would be theoretically good, so there's an amyloid PET scan where they inject something that binds to these plaques, and it's attached to a radioactive tracer, and then they put a camera in your head and they can see where in your brain these amyloid plaques are, which sounds great, except that it's not covered by insurance yet. And I think it's like $5,000 to $8,000 or something. So nobody's doing that. Very few people, unless you're in a research study. Some of the research studies will do it for free, so that could be sort of a reason to be interested in research studies. Although mostly you're supposed to do research studies because you just want to help the world as a volunteer, and not because you're getting any benefit, because you're not guaranteed any benefit. Anyway, that's a whole other story. But so there's spinal fluid, there's amyloid PET scans. You can do a glucose PET scan, which tells you something about the metabolism of different parts of the brain. So if there are parts of the brain that are very underactive because they're having a problem, they don't take up as much glucose, and so they don't take up as much tracer, and they put the camera on the head, and you say, aha, the activity in the hippocampus is low, the metabolism is low, and I know that because the sugar uptake is low. So if you meet criteria for dementia, and you have one of these things as positive, either a metabolic PET is convincing, or an MRI maybe is convincing, or the best thing right now probably is the spinal fluid is convincing, and we say, okay, you have probable Alzheimer's disease. And probably somebody's going to ask me at the end of the talk, so I may touch on it right now. There's this newly approved medication called Aduhelm or aducanumab. It's an IV antibody that they infuse into your arm, and it sticks to the plaque, and it causes your immune system to clear out plaque out of your brain. And it sounds like a great idea, except that the studies were kind of weak, and the FDA kind of just barely approved it, and everybody nationally is struggling with which patients should be offered this medication, and Medicare hasn't decided to pay for it yet, and there's a lot of questions, but there's significant risks with it. can cause bleeding and swelling in the brain. And in the studies, some of those patients had to go to the hospital because of the bleeding or swelling in the brain. So it's not at all clear, but hopefully over the next few months, we're going to come up with some kind of idea of who, if anybody, should be offered this medication. But so I guess that might be one of the reasons why you would want to get one of these tests I was mentioning is to figure out whether you might be a candidate for this Aduhelm, because we think, based on the studies that led to the FDA approval, that it was the people that got the high dose Aduhelm who had mild disease who maybe benefited. But anyway, my original point I was going to make when I started talking about Aduhelm is the FDA approved it, and then within a period of weeks after that, they changed the label. The change that they made was, first they approved it for Alzheimer's disease, and then they said, okay, we're going to restrict the label, and it's only if you have Alzheimer's disease and mild dementia or mild cognitive impairment, which is confusing because, I mean, traditionally, years ago, we used to think of mild cognitive impairment as not dementia. If you don't have dementia, you don't have Alzheimer's disease. But I do think that we're going to get to a point where, with a combination of scans and blood tests and spinal fluid, we're going to be able to say you have Alzheimer's disease because of your protein pattern or your scan or something, but you don't have dementia because you're still functional and your memory is good, but you're headed that direction because we can see the proteins in your brain or your spinal fluid or something. So I think that's probably what they were getting at. What they should have said was, this medication is indicated for dementia or mild cognitive impairment that the clinician believes is due to Alzheimer's disease. That would have been good. That's what they meant, I think. You can have mild cognitive impairment, so that's another concept you need to know about. So mild cognitive impairment, or MCI, means you're still pretty functional and independent. You don't need assistance with it much. You do pretty much everything yourself, most things. But you have detectable cognitive impairment that is more than your peers. Like, typically we'll say if it's more significant than 95% of people the same age and education. So you can have detectable cognitive impairment and still be very functional, and so we call that MCI, or mild cognitive impairment. If your attention is not normal for any reason, then you can't adequately make memories. So if your attention is abnormal because you're on too much sedating medication, or your attention is abnormal because your thyroid production is too low, or any number of different things. Almost any medical disorder, if it's severe enough, can affect your attention. If you have severe pneumonia, it might affect your attention. If you have a severe urinary tract infection, it might affect your attention. Anything that affects your attention is going to affect your memory. People that have some mild memory issues and they're going through some kind of severe stress with family or their job or house or something like that, moving, and cognition just falls apart for a while, and then things calm down and cognition gets better. So there's something about stress that causes impairment of memory, or it's a risk factor for memory impairment. And then that kind of goes together with this idea of the information overload, that if you're one of these people that's trying to do 22 different activities every day, at some point, sometimes it's just too much and you can't remember them all. Sleep deprivation. There is actually, I told you about the amyloid PET scans that can measure how much amyloid plaque is in your brain. There's actually a study showing that if you're sleep deprived for one night, you build up excess amyloid in your brain on an amyloid PET. And it's certainly the case that if you don't sleep well at night, then the next day you're not going to perform as well on cognitive tests. But it's also the case that we think that chronic sleep deprivation may be a risk factor for dementia and Alzheimer's. Anxiety and depression and impact memory greatly. A lot of times patients are seen in a neurology clinic with confusion or memory issues, and it turns out that they're actually having seizures, so we always have to be on the alert for that possibility. And then many, or potentially all, medical conditions, if they're severe enough, may impact the brain and therefore may impact memory. So we have to be on alert for everything. This is just a curve showing some amyloid PET results. So it seems to be that even in people without mild cognitive impairment, so in other words, you're in the pack with 95% of your peers, and the people that deteriorate cognitively faster are the people that have more amyloid in their brain, even people that don't have dementia and don't have MCI. So these are a couple of just very common medical conditions, general medical conditions that your primary care is probably hopefully screening for, but which affect your risk for dementia and for memory loss. Diabetes is a very strong risk factor for Alzheimer's disease, that's why I put that on. Thyroid, too high or too low affects memory. Blood pressure, too high or too low can be a problem. Chronic high blood pressure seems to cause buildup of plaque in the arteries, and that contributes to dementia. Low blood pressure, especially low blood pressure as you get older, causes not enough blood to go to your brain, and that causes malfunction of the brain. Every time you go into your primary care doctor, you need to be reviewing your medication list. And then nutrition, some of which we can assess with lab tests. And I think for anybody that's developing cognitive or memory issues, it's probably a good idea to at least check a blood level of vitamin B12, because that's such a common deficiency. It's so easy to treat and so bad if you have it. But I think other vitamins too, like I've started checking thiamine, folate, and also just looking at your nutrition. Are you eating vegetables in your diet? I think, everybody asks me also at these talks, like, well, which food should I eat that's going to cure dementia or prevent dementia? There's no one magic food, but I think the answer maybe is like, eat as many vegetables and as many different vegetables, accounting for medical necessities, like if you're on Coumadin, you may have to be cautious with certain vegetables, that kind of thing. But I think that the basic answer that most doctors agree is like, more vegetables and a variety of vegetables is a good idea. Something like the Mediterranean diet. Some more potential risk factors for dementia. I mentioned the first two. Hyperlipidemia, that's another one. There is a blood test called homocysteine, which is a metabolite that builds up if you don't have enough certain B vitamins. So that's one that often gets overlooked, but it's easily included with other blood tests when you get your electrolytes and complete blood count and your diabetes screening. Somebody could throw in a homocysteine. If the homocysteine is elevated, it suggests you may not have enough B vitamins, so you could take a B complex or some special cocktail with B vitamins. Smoking is sort of obvious. Excessive alcohol, probably not good for the brain. So low educational attainment is a risk factor for dementia, and I think that's a really interesting one. We don't know why that is exactly. Sometimes people will think about the idea that you've got more connections or more redundancy or more backup systems in your brain. So if you lose certain neurons or certain circuits as you get older, you've got more backup or something. But what I think is an interesting question is like, when does the educational attainment have to occur to have an effect? You can continue to educate yourself throughout your life and build new connections in your brain. And I think that's a good idea, and I'm going to touch on that later. There are connections between the balance circuits in the brainstem, the vestibular nuclei, and the part of the brain that gets involved in Alzheimer's disease, the entorhinal cortex, and probably other parts of the medial temporal lobe. So it's probably the case that your brainstem vestibular balance system contributes to your ability to navigate. Like, I walked in from the front door out there, right? And if you blindfolded me and said, okay, walk back to the front door, there are cells in my temporal lobe, in the entorhinal cortex, that would allow me to say, okay, if I'm going to start walking, I know how far I've walked, and I know generally where I am on this map of the building, and I don't know if I could do it or not. Maybe I should try. But there are circuits that do that we call navigation, and the balance system contributes to it. So in addition to being interested in memory, I'm also very interested in dizziness and balance. It's one of my subspecialties. So I'm very intrigued by this idea of if you tuned up that system by doing physical therapy and training your balance, then could you somehow help the cognitive system? At least the navigation part. But that's speculative more than anything else, I guess. But I think it falls into the category of maybe problems with the balance system reflected or represent a risk factor for dementia. Risk factor for dementia. I wanted to have a slide in here about the screening program. So one of the questions that people have with respect to memory is, under what condition should I go see a doctor about this? And our hospital locally and others elsewhere sometimes have these screening programs that locally, since you're here locally, I'm talking in Orange County, I'll mention that Hoag has this screening program where you pay a small out-of-pocket fee. I think it's $45. It's subsidized by the hospital, and they do a reasonable screening test for you to detect memory problems that are out of proportion to what you'd expect for your age and maybe education. And so that's through the hospital's vital brain aging program. So I think everybody has the handout, but if you're watching this later and don't have the handout, I think you can just Google Hoag vital brain aging and memory, and you'll probably find that there's only one phone number that seems to be on all the web pages. So if you're in Orange County, you can contact the hospital and get this screening, and then they'll either tell you you're fine, you're in the middle of the pack, it seems, and come back next year and get checked again, or we think there might be something going on. They don't make diagnosis, but they would flag you as saying you might be having some problems. Maybe you should go get checked out. But then, what happens when you go see the doctor? So let's say you've already decided that there is a problem with your memory or other aspects of cognition. And by the way, I'll stop there and say, so cognition encompasses not just memory, but other things too. So I mentioned navigation, like finding your way back to the front door blindfolded. But there are other aspects of cognition too, like ability to speak and read and write and understand language. Another one is organization and multitasking, executive function. So if you're having problems with any of these things, and it's becoming a serious issue that you think is out of proportion, or your family thinks, or your doctor thinks is out of proportion, what should be done medically? Well, first of all, you have to probably build a team. So you certainly need, or would benefit from having a primary care doctor. The behavioral health providers, so that's like psychiatry, psychology, counselors, often become a very important part of your team. Not only because having these types of disorders can be very stressful and anxiety-provoking and precipitate depression. If you have an anxiety or depression disorder that was pre-existing before you developed a cognitive problem, then your psychiatric depression anxiety disorder may be contributing to your dementia problem. And if the dementia came first, then we usually think of it the other way around. But either way, it's something that sometimes the primary care and the neurologist can treat, but sometimes if there's a lot of emotional component, a lot of depression, a lot of anxiety, then there is an indication for multiple medications, that some of which have a lot of side effects and they're hard to combine them, and the psychiatrists are really good at all that stuff. So sometimes getting a psychiatrist involved is helpful. Physical therapy can be very important. I mean, even if you set aside my speculations about treating dementia with physical therapy, a lot of people who develop brain disorders do have walking problems and have an elevated risk for falling and injuries. Most people who have balance and walking problems who go to physical therapy get some benefit out of it, and that's something to keep on the short list of interventions. If you have a memory disorder, then you may not remember all of your history. You may not be able to tell the doctor what happened last Tuesday. So it's really helpful, and some clinics insist on this. It's really helpful if you can bring somebody with you. If you're going alone to your doctor visit, or if you're going, let's say, independently to see a doctor about your memory, it's really helpful if you can bring somebody with you that knows your history or knows how you've been functioning as a sort of a corroborating source or another perspective, let's say. Families hire assistants to be in the home and caregivers. But, I mean, even if it's not that severe, if you have some memory impairment and you're taking medication for your memory impairment, there's a good chance that you're at risk of forgetting to take your medicine for your memory impairment. Having somebody double checking that you're taking your medications is a really good idea. So I wanted to talk a little bit about some non-drug approaches to reducing your risk of dementia, in other words, treating MCI, mild cognitive impairment, continuing to learn, continuing your education or self-education on some appropriately challenging subject. When people start learning new things, new hobbies, new subjects, new skills, that it builds cognitive, intellectual ability. And so I would encourage you to do that. There's so much that's free online now from universities. You know, you could take a whole university course from a top university with like homework assignments and solutions and exams and videos and readings, and it's all free online. So, I mean, I've been trying to sell this concept to my patients and not getting very far with it, so I'm not sure why people don't want to learn. I guess if you grow up with the idea of learning in a classroom, then the idea of learning from a computer screen it's not natural. We saw that all the last year with the kids trying to learn, you know, on Zoom from school. It was very difficult for most of them. So maybe that's the problem, but I do think it would help. But you could do something different. You could have, you could just have like an instructor or a staff person or a family member who encourages a person with dementia, or someone with mild cognitive impairment could encourage themselves to take out a workbook and work on something a certain number of minutes per day. I think probably a lot of you have had the experience of hearing a song that you're familiar with from many years ago, and it somehow transports you back to the same situation and the same feelings that you were having many years ago. And you know, I like to think it's because the hearing cortex is in the temporal lobe right next to the memory cortex. I don't know why it is. We don't understand neural circuits in the brain, but I mean the empirical reality is music can be very emotionally powerful and also bring back memories that you have from a long time ago. So I mean, there's a lot of interest right now in trying to use that phenomenon as a therapy. And there was an interesting NPR broadcast recently about, you know, a woman who had gone to visit, I think it was her mother was at a memory care unit or something like that, had dementia and was not talking at all, and then the daughter, you know, played Christmas carols on the piano, started singing with her, and the mom started singing, and then she started talking, and it somehow woke up circuits in her brain, and you know, it didn't cure her dementia, but she wasn't talking before, and then she was talking, and so she was starting to communicate with people a little bit. There's a thing called reminiscence therapy, where it's been known since the 1960s that you can get this effect that psychologists can show, where if you expose people to things from when they were much younger, like if you build you know, a room that's filled with logos and storefronts and cultural elements from when the subjects were much younger, like they were in their 20s, and you can see a change in cognitive test results after exposing people. And so that also seems to wake up memories. And I'm not suggesting that, you know, it would be great if every community could experiment with this reminiscence therapy thing and building, you know, little towns that look like they're from the 1960s or 70s, and maybe I could go see a Jimi Hendrix concert or something. But it's going to be very expensive, but maybe there's simpler things that you can do, like even just listening to music from a long time ago, and then maybe having a conversation after that. I think it has, as I said, the potential to wake up circuits in your brain that weren't awake before. Music. Video. So it's analogous to the reminiscence therapy idea of having people spend 5 hours in a town that was built to look like it's from the 1960s. What about just having somebody watch a video of the first landing on the moon or something, and then having a conversation about that? Some memorable event that has a good chance of waking up some circuit in the brain and then getting people talking that way. So right now I'm talking about people with dementia and awakening functions that are asleep, but maybe the same kind of phenomena can apply to people with milder deficits, or even all of us. So maybe maybe all of us should do a little bit of reminiscence of remembering what we were thinking about when we were 20, listening to some of the music that we listened to back then. Maybe that'll wake something up. Meditation, or for some people, prayer. I mean, there's all kinds of studies on meditation, but if nothing else, the practice of meditation may sharpen your attention. And like I was saying before, if your attention is better, you're better able to form memories. So, I mean, the simplest thing is, and I'm not an expert on this, but mindfulness meditation, I think, has to do mostly with focusing on one thing like your breathing and just continuing to focus mostly on that. There's a book called The Relaxation Response, which is like a simplified version of mindfulness meditation. That has a lot of potential. And then any kind of hobbies that involve a diverse intellectual engagement, exercise may reduce your risk for dementia or for cognitive decline. There was actually a clinical trial, may still be going on, the Exert study that was at UC Irvine, where it was very simple. It was like you go to the YMCA and walk on a treadmill with a trainer a few days a week. That was like the whole intervention. Other people may have to do other types of activities, swimming, or some kind of doctor-approved cardio. Has a lot of potential to sharpen your attention and memory, maybe reduce your risk of dementia. Socializing with friends and family. So people that interact more with other people have a lower risk of cognitive decline. So that's been very hard again in the last year, but as opportunities come up safely to start to socialize more, I think that's a good. What about interventions that are specifically targeted at trying to improve your memory? I don't think there's any one thing, but the simplest thing is to just practice memorizing things. So memorizing lists of words. So a lot of our diagnosis of dementia and of Alzheimer's disease, it nationally is based on these tests that have to do with memorizing lists of words. And like this memory screening that I mentioned from the local hospital here, the core of that test has to do with memorizing a list of words. There are other aspects to it too, but that's something you could do. You could write down a list of 10 words and look at it for a minute, and then put it away, and then see if you can write it down without referring to the list, and practice doing that. That's easy to practice, and will that help your risk of dementia? Well, I don't know, but it seems to be the most commonly involved ability that neuropsychologists have identified as a marker of Alzheimer's disease. So to me, intuitively, it makes sense to practice it. There seems to be something about visualizing information. So, I mean, a lot of times people talk about this trick where you'd have a fixed series of places, like your places are like the auditorium, the lobby, the parking lot, the library. And if you're trying to remember 5 things, like you put one thing in your mind in each location and remember the first thing sitting at the lobby. So that's one approach, but that's pretty complicated. It works for some people, it may not work for everybody, but I think just using visualization and remembering things as pictures has a lot of potential. So that could take a lot of different forms. If you're trying to remember, I need to go to the grocery store and pick up bread. Now, don't pick up bread, because that's just carbs. You need to pick up some mixed vegetables. You need to pick up vegetables and olive oil. You could repeat the words to yourself. You could say vegetables and olive oil, and then you could also imagine what those things look like, and say, okay, these are the things I have to get at the store. And you imagine a picture of the vegetables and a picture of the olive oil. Then when you get to the store, you've got kind of 2 types of memory. You've got the words that you said to yourself and the pictures. Or write it down. That's another way. Make a shopping list. So, I mean, that's one of the most powerful compensatory strategies for memory loss, is just write things down. Organization and routines. Patients who have what appears to be profound dementia in the hospital, and when you talk to family or friends, they say, oh my gosh, they seem to be fine, but they've been living and spending their time in the same neighborhood for 50 years, doing all the same things, the same routines, the same landmarks, the same visual cues. And in that environment, people can do fine, even sometimes with a surprising amount of dementia. But then if you take the person out of that environment and put them in a disorienting, unfamiliar hospital environment, they may appear completely demented. So you can help yourself with that dichotomy by giving yourself cues. Anything you can do to make your life more organized, and give yourself visual cues, written lists, systems, standardization at the same time that you do things. These things will impose a structure that will make it easier for you to remember things, even if you're starting to develop some issues with your cognition. All right, so I left hopefully a fair amount of time for questions. There are always questions of this type of talk, so I will take some questions. So, yes?
Are these two conditions hereditary?
So I think the question is whether Alzheimer's disease and dementia are hereditary. And they're usually not strongly hereditary. So there are rare forms of Alzheimer's disease that are determined by well-defined genetic variants, but most people don't have those. And most people who have those, most families that have those, that I've seen anyway, develop dementia very early. Like maybe people in the family develop dementia in their 40s. It's not a hard and fast rule, but so there's a tendency for Alzheimer's disease to run in families a little bit. I would predict that in the next several years, we're going to see more people getting the whole genome or the whole part of the whole genome, that whole exome sequenced, and we're going to see patterns that get identified that are more useful in predicting which people are headed toward dementia. We're going to have all kinds of tests coming out to identify people, that probably better than by asking, do you have family members that have dementia? But yes, there's a little bit of an excess occurrence of dementia in families of people that have had someone before that had dementia. I'll come around here in a sec, but yes? Go ahead. Yep.
Yes.
Yes. Please.
Excuse me. What memory medications do you recommend? You mentioned something about it.
Yeah, so the question is about what medications exist that help with memory, and the medications that we have are two main classes. So there's the ones that prolong the lifetime of acetylcholine in the synapses between neurons. So neuron A releases acetylcholine to talk to neuron B, and the acetylcholine lasts for a while in the synapse, and then it gets degraded, like erasing a blackboard. Acetylcholinesterase inhibitors prevent that degradation or breakdown of acetylcholine, so the message lasts longer, so the acetylcholine hangs around longer in the synapse, and the message maybe is more reliable or something. That's one class. That's the donepezil, galantamine, rivastigmine class of medications. And then the other class is a class of one that's memantine, or Namenda is the brand name. That one acts on a different type of neuron, on glutamate neurons, in somewhat unclear ways. And originally the thought was that memantine was going to maybe reduce your risk of losing neurons over time, and which is, you know, a great idea. And so I always have that in the back of my mind, that maybe if I start that early, it'll have some kind of protective effect. But short-term, memantine, like the cholinesterase inhibitors, boosts short-term memory and other aspects of cognition. So we've got these two classes. And then the other meds that come into play often are the psychiatry medications, the antidepressants in particular. So a lot of people who have either dementia or mild cognitive impairment develop an associated depression or some partial criteria for depression. And what I've found is that sometimes when you start antidepressants for those patients, that mood improves, but also cognition improves in some people. And so that's like a common one is escitalopram or citalopram, but there's a whole range of different antidepressants that could be tried. That's a short answer to what meds are out there. And some medicines need to be reduced. So if the acetylcholinesterase inhibitors like donepezil prolong the lifetime of acetylcholine and make the message more reliable, drugs like oxybutynin for the bladder block acetylcholine and derail its ability to do its job. So sometimes there are medicines that need to be reduced in dose or stopped entirely. I'll keep going in counterclockwise. I left in the back.
Are there any research studies for non-symptomatic people with a family history of Alzheimer's?
So the question is about research studies of people that don't have symptoms of dementia, but maybe related to dementia, but in people that don't have symptoms of dementia. Yes, actually, there's an increasing number of studies like that that are aiming to follow and maybe even treat people that have PET scan evidence of amyloid. So Yes, I think you're going to see the emergence over the next couple of years of a number of studies that are enrolling people that don't have significant memory impairment, but may have some other reason to be at risk. So yes.
Is Aristotle still used and is it effective?
So the follow-up question was, what about Aricept? Are we still using that? So Aricept is the brand name for donepezil, which I was talking about a second ago. It absolutely is indicated for people with dementia. It does, in my opinion, also help people with mild cognitive impairment.
This happens to me all the time. I'm talking to some people and telling a story, and I forget the word, but I see it here, but I can't say it. Is that part of my road to one of these?
We do see that kind of phenomenon, difficulty with word finding, as one common feature of dementia and Alzheimer's, but just occasionally not being able to think of a word, I don't think is in itself too alarming. I mean, if it's happening every day, maybe it would be a reason to ask your doctor about it. An exception, though, is names, like names of people, names of places. That those are hard for just about everybody, and fall more in the category of, you know, what I was calling aging, which, you know, we say normal aging. We don't like to think it's normal. We like to think that, you know, someday we're going to understand aging and figure out how to fight it off or something. But it seems to be almost universal that over a certain age, like certainly over age 70, that most people complain of some difficulty thinking of names. But if it's something that's not names, other nouns, objects, or other words, might be, if it's frequent, I'd say if it's more than once in a while, then it's worth talking to your doctor about it. It doesn't prove anything, and even if you said, yes, it's a serious problem, there's some medical disorder that's causing it, that doesn't mean it's Alzheimer's disease. You know, like we've been talking about, there's, you know, 30 common things besides Alzheimer's, and it could be medications, it could be a hormonal or metabolic problem, it could be a lot of things. So it's one of those cognitive issues that it's a legit reason to talk to your doctor about. Is there a disorder, and if so, is there is there an impairment? In other words, are you having more trouble than others the same age? And if so, what's the list of possible contributors to that? And so I think some doctor has to systematically go through those possibilities. Okay, well, thank you very much for